A very good evening to you tuned into UBC TV. Thank you so much for following all our programs and welcome to tonight's edition of UBC One-on-One with Micheal, Jordan, Lukomwa. COVID-19 is still becoming a problem, although we are fighting on, and on several occasions we will take time to pay attention to it, getting to understand various issues, because mostly what we need is information. We are here again to discuss something to do with COVID-19, not only an issue but a number. And I have, we'll hear from the host's mouth this time round. We have officials from the Ministry of Health who want to ask them a number of questions that are in the interest of you and me, the public, to do with the lockdown, vaccination, and issues to do with accountability. So please get that cup of tea and be part of the program. Join me, welcome officials. We have Dr. Sarah Biachika, the Commissioner for Planning in the Ministry of Health. Doctor, you're most welcome.
Thank you.
We have Dr. Richard Kabanda. He's the Commissioner for Health Promotion. We welcome you, Doctor. And on the extreme end is Dr. Dr. Alfred Driwale, the Assistant Commissioner for Immunization Program and Vaccination. Sir, you're most welcome.
Thank you.
Yes, we are under a lockdown, and the target is to ensure that we bring the figures down, the pressure down to do with this pandemic. I'll start with you, Dr. Kabanda. What results so far do we have in terms of the lockdown helping us to curb the spread of the pandemic in Uganda?
Yeah, thank you, moderator. Taking you back, of course, if you look at the number of days we have spent now, ever since the president pronounced himself on a preventive measure of having the lockdown, partial lockdown in place in the country. So we're almost now 4 weeks ever since that pronouncement was made. And at that point in time, before 10 days before the lockdown, our positivity rate was between 18 to 20%. That means that every 100 people that were being tested at that point in time, we could get around 18% of those that were positive. So currently we have seen a drop as of now, and it's average, on average it's between 8 to 10%, a drop in the positivity rate. And of course the positivity rate has nothing to do with a slight drop in the number of people being tested. Okay. Because literally you're looking at how many people have been found to be positive. So of course we know that for COVID-19, it's the way it is being transmitted or being spread from one person to another. It's us individuals who move it. And at that time we realized that the risk perception was very low. And what happens at that point in time, that everybody within different parts of the country thought that the disease was normal. And movements were normal, interactions were normal, schools were operating at that point in time. And of course, all these other congregation settings, churches and funerals, parties at that point in time. So it's a human in nature. When the risk perception is low, people tend to not to follow SOPs. And COVID being a new disease, definitely there's quite a lot that we have learned from it. But currently, after that point in time when the pronouncement was made, and of course the drop speaks volumes, mainly on two key issues. Number one, with the increased rate of infection, many families as of now have experienced either having lost a loved one or a relative or a friend. Many people or families have seen or heard or experienced having people being hospitalized. And of course, many families across the country have also attended to a number of people in their homes through our home-based care approach.
Yes. So
what that indicates is that that increases the risk perception. People definitely get to know that the disease, COVID-19, is real and it's close to us. So two major drivers of why we are seeing a drop currently in the positivity rate. Number one, mainly because people are no longer congregating. That partly explains that we have had
congregations and movements are limited.
Yes, a decrease in movements and that partly explains why the spread of COVID-19 has reduced a bit. And the other key driver is, of course, the risk perception. We have seen that has increased, and people have definitely now tried as much as possible to observe SOPs in terms of use of masks across, so that partly explains. But members of the public should know that the drop should not excite people, because
the problem is still here.
The problem is still here. 8, 9, 10% in terms of positivity rate is high, because once we congregate again, chances are high that the spread will be faster than we anticipate, because one positive person can actually infect between 20 to 40 people. So that literally means that if we congregate again as of now, we can still get back to the third wave. Okay. So what should actually worry us as of now, and making sense of that drop, is that in terms of admissions, in terms of us seeing people who need special care in hospitals, we are not seeing a drop. Instead, we still see very many people actually being hospitalized. And that also partly explains why we still have many people who are still dying as a result of COVID-19.
Okay. Thank you so much, Doctor.
Okay.
Dr. Driwali, vaccination must be under your charge. Am I right?
Yes, you are right.
How much have you taken advantage of the lockdown to ensure an achievement or success in that area?
Now, these are two different things. The acceleration of vaccination coverage is driven by availability of vaccines.
Okay.
So the lockdown is one of the preventive measures, so that if someone is infected in one area, he remains there without taking it to many other places, to many people. So vaccines would come in to consolidate this downward trend we're seeing as the third layer of protection.
Okay.
You remember social distancing, sanitizing, masking. These are the standard measures we're using. Now, the fourth is a vaccine.
Yes.
So if they're right now, as we are, we have people who have got 4 layers of protection, those who are already vaccinated, while the majority of the population
have not vaccinated.
Have not been vaccinated. And the main constraint on vaccination program is the scarcity of vaccines in the global market. And I think this is what we now need to appreciate. Globally, there is a shortage of vaccines in terms of production. There is also a challenge in distribution and in equitable distribution. I can tell you, over 2 billion doses of COVID-19 vaccines have been used globally. But Africa has used only around 58 million doses. So it means the rest of the world is vaccinating itself. Africa has limited access to vaccines and also limited use. Now, in terms of average of vaccination, in Africa, we have 1.1% of the people vaccinated. But in other parts of the world where you are seeing football is now being played,
yes,
they have vaccinated about 50%. So vaccines are critical, and always, as I prefer to say, when we get the vaccines, we quickly engage in the wrong conversation. Side effects, this and that. So we are creating a challenge which is uncalled for. The real problem is not the efficacy of the vaccines. You can see the other economies are opening up. Our real challenge as a country, as a region, as a continent, is access to vaccines, which is very, very limited. Currently, as I speak, in Uganda, we have 1.9% of
who have vaccinated,
who are now fully vaccinated. That is a drop in ocean, and it cannot be safe.
So the stumbling block between within the road to have each one of us vaccinated in Uganda is scarcity of the vaccines.
It's scarcity. Even with money in your pocket, there is not money is not guaranteed. You don't get the vaccines and vaccinate your people.
What does that mean to our situation now? Aren't we going for another lockdown? Because if they release us to get back to work, when the biggest number of us is not vaccinated,
yes,
the spread will go
precisely
back high, like Dr. Kabanda said. Doesn't that mean the president will still send us back home?
You see, the conversation about COVID-19 should not be taken even to the level of the president. You see, disease prevention requires individual responsibility. Putting on a mask is your responsibility. So what, in other words, I'm communicating is vaccines are good, but this rate at which we will be acquiring the vaccines is not totally in our hands. So we will have to comply with the SOPs longer. The masks, we must wear them longer. The SOPs and so on. And we also need to work on our psyche. That we may in future be having intermittent lockdowns. Intermittent lockdowns will be one of the things to work with. We need to work on our psychology so that you are not angry. You will be angry if you don't understand why you're being locked. But if you understand why we're being locked down, then you face the lockdowns with a different attitude.
Doctor, I want you to clear the air about some two things here before I come to Dr. Sara's side.
Right.
There was information that a number of people were vaccinated with the wrong vaccines. In fact, in some domains, it's water that is said. How true is that? Secondly, there is also information that people that were vaccinated actually are the ones that died more. What is the truth as you, the man in charge of vaccination in the Ministry of Health?
You know, COVID-19 comes with what they call infodemics. Too much information which is uncensored, and it creates actually a big problem. And it is a well-documented fact because people are anxious. Now, there are also people outside there who want to take advantage of anxious people. So vaccines, there is nobody who has come forward in Uganda that I was injected by this man. I don't know what he injected me with. Let him tell his story.
So officially you don't have such information?
Officially there is no such a story that this man injected me with something else. Now that they are fake vaccines, he is here.
But have you heard of it?
Nobody has come. Now that's the beginning. So this speaks to a dishonest public. So the stories of people being injected with something else we had. But who to follow on that investigation, nobody has been presented as such. Now, number two, there are people who...
Before the doctor,
yes,
as the ministry and a department in charge of vaccination, what measures did you put in place to guard the public of such acts? Because yes, you may not have such official information about it, but with the unscrupulous kind of people that we have in our communities everywhere in the world, did you think about that as a ministry, and did you put up any measures?
Too well. You see, that is the starting point. There are people who have been
because people
arrested.
could be very unscrupulous to an extent,
yes,
that you may not get the official information.
Yes.
Where does that leave the Ugandan?
We put measures in place. But let me start with this common mistake, where people are not responsible to report. That's the beginning. But the systems in place, security systems, picked people who had vaccine materials which they refer to as vaccines. This matter is under investigation, so I'm not going to make comments with respect to that. The third group, there are people who were moving with the vaccines which were able to confirm that they were not fake vaccines, but they were stolen vaccines. So those who were vaccinated with the stolen vaccines are safe. Those who were vaccinated with other products, it's under investigation. We are also investigating what was in that bottle. We will support the public with that information. So nobody knows what they were injected with, because the batch numbers on that bottle are not the batch numbers we had, and we are doing extensive investigations to find out whether those were fake, whether they came from a factory or from a neighboring country. So this is the. But in terms of how prepared we were, our national vaccine deployment plan anticipated that because of scarcity, such things were going to come. That's why, if you see the way these vaccines are delivered to districts, there is security presence. I don't know whether you noticed that. They are not just taken like that. They are taken under full escort to ensure that they are safe. When they reach the district, they are delivered in the hands of the district security team, and there's clear guidelines on vaccine and commodity security in the store and at the point of use. Now, once those, and that's why, by the way, the issue of theft of vaccines is not as rampant, because the measures are there.
Although it's surprising that with the escort and the security,
yes,
again the theft was recorded.
Yes, and you see, human beings cannot be controlled like you are controlling timber. They will always find some way. But if you see, I can now tell you authoritatively, vaccines which were stolen are coming from 3 districts out of 46 administrative units. So this is really something which we cannot say the measures failed. The measures worked. And also we are able to know, if I can tell you authoritatively where they are coming from, it means the measures to safeguard these vaccines as a whole of government approach exist.
Okay, doctor. Did we lose people due to having been vaccinated?
Now, that is another issue. Vaccines are not a preventive measure against the death from all sources. Therefore, once you are vaccinated, whatever disease you had, you'll be protected. No. If you had hypertension and you don't control it, if you had diabetes, you don't control it, and you had TB, it is not treated, and you are vaccinated, the TB can still kill you after vaccination. And that's why we have a mechanism of pharmacovigilance, a system that picks deaths after vaccination, not due to vaccination. A death which follows vaccination is picked and investigated. The results have been very humbling. That's why as a ministry you don't see us coming out to on a panic mode. If you are vaccinating people and they're dying, that's a serious issue. What we have found,
you would have halted it.
Yes, we would have halted. That's why we monitor. So the reason why we have not halted is we have found the people who have died after vaccination. I can tell you, one of them died because of TB. Another one died because he had diabetes. Another one actually complained that his leg was rotting because of vaccination. It was during our investigation for the first time that he got to know he had diabetes, which he didn't know.
Thank you so much, Doctor.
I think, Mr. Lukomwa, before you cross to Dr. Sarah, there is something pertinent which I think Dr. Alfred has forgotten on the strategies of government. 2 key issues here. First of all, you would wonder why the public ought to go and buy or source for people to go and vaccinate them at a cost, when government has indicated openly and broadly that vaccination program is completely free. Okay. So members of the public should definitely desist from going to that direction. And of course also the other key approach was that we have not had an opportunity of allowing the private sector.
So in fact, whoever could have gone and was vaccinated with the wrong drug should have themselves to blame.
Actually, if you talk about corruption, that's one angle that we need to look at.
Okay.
Because why should, if they say that malaria treatment is completely free, why should I look at other ways of getting malaria, anti-malarials at a cost?
Okay.
Of course, through other ways. And of course, the other key also issue is that our colleagues in the private sector have not been fully opened to ensure that they do vaccination at a cost. Because government anticipated that due to high demand with low supply, if you allow the private sector as of now, chances are high that individuals will start advising means or ways of how they can be able to have vaccines which are either genuine or not genuine to the population. So those are two key measures which government instituted, and I think that members of the public should know and be able to comply with the direction of the sector.
Thank you so much. That's why we invited you, because we want to know a lot.
Now, about death after vaccination, let me just put this. If you were vaccinated at a time where you were already infected, incubating the disease, the vaccine takes 2 weeks to have effect, right? So it means this pre-existing infection will progress unfettered. Number two, if you have your vaccine and you acquire an infection within the period where the vaccine has not produced enough antibodies to fight, the effect on its outcome will be limited. Number three, no vaccine has claimed to be 100% effective. If they say a vaccine is 80% effective, in other words, it is 20% ineffective. If you're protecting 80% of the problem, that is the public health benefit we look for.
Okay.
We also agree that there is a phenomenon referred to as breakthrough infection. Breakthrough infection, you make that conclusion if someone gets infected after 2 weeks of getting his second dose. Most of the deaths which we are attributing to vaccines were within those periods where people had one dose, others had 2, but they died within less than 2 weeks, and so on.
Others had comorbidity.
Others had, by the way, people who were vaccinated were selected by risk. We said people with the comorbidities were a priority because we needed to control them. But this vaccine is not what is called a therapeutic vaccine. It is,
okay.
Yes.
Thank you so much, Doctor.
Right.
Dr. Sarah, you are in charge of planning. Whatever the whole ministry comes out with, you must be involved here and there. The president, while looking us down, he says, I am basing on the advice given to me by these experts. I'm sure you must have known very well that there are no vaccines. You must have known very well whatever the challenges the two colleagues have given. How did you advise the president to send us home without a plan to vaccinate all of us, a plan to ensure that we are totally safe? Because according to Dr. Driwali's explanation, after this lockdown, when we get out home and get back to our shops and the markets and wherever, the infections may still go high, and the president still, on your advice as the Minister of Health, will send us back home. What kind of plan did you put on the table for these other colleagues of yours to take action?
Thank you very much, moderator. We do have a plan, and we've been having this plan ever since the pandemic was declared by WHO way back in February last year. We immediately, as Ministry of Health and other stakeholders, sat down and developed a comprehensive plan, which was costed. And this plan has been guiding us all through the last year and also this year. We have even we reviewed that plan, which was actually to take us for a period of 18 months up to June this year. And we have also developed another plan which we are calling the Resurgency Plan.
What do you involve in the plans with the challenges ahead of us and just on the table as we move?
So all these challenges inform us because we have to have evidence-based plans. So we did make projections right from the start with different scenarios, knowing that if we undertake certain measures, the initial standard operating procedures of washing hands, because at first there was no vaccination, you all know that. So we started making our projections, looking at the worst case scenario, and we are saying, okay, in case there is no lockdown, people are free and probably putting on their masks, washing hands, how many people do we think would get the infection? Because using that, we're able to start our planning and say, yes, we must continue with sensitization of the community. So our plan has what we call pillars. And these pillars bring into play all those different actions that we have to undertake to control the pandemic. So first, we have to have coordination mechanisms right from the national level up to the community level, because now as the pandemic or during this surge, we are really strengthening the community aspect, community engagement, using the village COVID-19 task forces. But we start with the national task force, and then we have the district going downwards. So coordination mechanisms are in place. We had to ensure that surveillance is in place. Surveillance here means whenever there's an alert, you have to follow it up, you have to do contact tracing, and through surveillance, that's why you hear every day we give updates on the number of cases that have been tested are positive, and also we do follow up. So we established call centers and work through the district with the district surveillance teams. Surveillance goes hand in hand with the testing because you must confirm. So we also have to strengthen the laboratory network where we have laboratory hubs, and we have our teams moving even up to homes to pick samples for those people who cannot go to the testing sites or to the districts. Then very important is information, what we call strategic information. So we collect data, analyze it, and we can know where the hotspots are, where most of the cases are coming from. And with that, we are able to deploy our teams to intensify the case finding and follow-up.
In the current event where he is handcuffed that there are no vaccines, what is the way forward? What kind of plan do you have where he can't access vaccines to ensure all of us are safe?
Vaccine is still ongoing. We are still planning. For example, we have costed and quantified the vaccines that we require, the funding that is required. So the issue is even some money has been provided, but as he rightly mentioned, the issue is accessing the vaccines.
We have the money.
We have some money.
But what to buy and where to buy it?
What to buy is known, but where, how to get it is the challenge. I mean, it's not available. There's a lot of demand for the vaccines. Our target is to have at least 22 million of the people of Uganda vaccinated as the soonest time as possible.
How much steps have you taken? Probably, you see, when there's a challenge and it is so biting, still you don't see it. Have you taken some steps to ensure that no matter what the situation is, we must get the vaccine? What kind of steps have you taken?
Oh, the steps we have taken is that to use all available channels to access the vaccine. We have through the COVAX facility that my colleague mentioned, that is where WHO and other organizations are supporting the low-income countries to have access through bulk purchasing and facilitating the distribution. But the competition there is still very high. So the other option is to look beyond the COVAX. If as a country we can directly buy from the manufacturers, so that option is also there. So we are using all possible fronts to do that.
Okay. Doctor, you are in charge of plan. I'll give you some more time. There are complaints all over the country about you, the Ministry of Health, not you, the person, having received a lot of money all the time because of this COVID-19 situation. If I may ask, how much money did you receive during the first wave 2020, and how was it spent for the good of the Ugandan watching TV?
Thank you very much for that question. We did receive funding from various sources. and as I mentioned, to fund the activities as per
because
our plan.
when COVID came, there was a budget running. You got a supplementary. Then donations.
Okay. So as I was saying, different sources of funding. From the total funding that came directly within a Ministry of Health's budget, from government of Uganda, and also from external financing, but towards the with Ministry of Finance, was 739 billion Uganda shillings.
Okay.
And of this money, 337 was from government of Uganda, directly, government funding.
337.
Yes, 337. And this included the 29.6 billion that was cash contributions towards the COVID-19 fund. You remember His Excellency opened up and said people can contribute towards
Whoever
this.
can bring a coin or something.
And they did, and we really appreciate that we were able to raise 29.6 billion through that kind of donation. We also received in-kind donations, materials, amounting to costed to about 12.8 billion. And then we had other funding coming in through external funding to government. This included grants like from Global Fund, Gavi. We had funding which is a loan from the African Development Bank, which was specifically for procurement of test kits and PPEs, and this went to NMS. And we utilized these funds for all the activities that we had planned. These included procurement of the ICUs that you have had, ICU beds plus the equipment. We were able to procure ambulances, which you see now on the roads, moving up and down. We were able to recruit 437 health workers to support the management of the COVID-19 patients, and these have been deployed across the country. We were able to also manage our patients under case management, because once the patient is admitted, we have to feed them all through. So all these patients we've been able to manage. We provide meals. Because they cannot interact with their relatives. We've paid salaries, as I said, and hardship allowance. So for surveillance purposes, we had to deploy teams of health workers in the local governments across the about 54 points of entries across the country along the border points. And all these teams had to be paid hardship allowance of 80,000 per day. Which 80,000. Munana.
Okay.
Ranging from 55 to 80, depending on the role you are playing. So we had to pay them all the time they were there. So those are the kinds of activities we have been using this money for. And the donations we appreciate. These were in-kind donations, some of them medical and non-medical supplies. And these were also distributed across the country. We appreciate
the money. Let me start with the issue of the health workers, your bit. So the money to ensure they get these allowances and the PPEs was released from your office and the people in charge.
Oh yes, Ministry of Health has paid off all that money to the...
I've seen a number of press conferences of health workers, their unions, complaining about PPEs and these allowances. What could have gone wrong then?
In terms of allowances, the ministry pays allowances based on the requests or submissions that we receive. As I mentioned, there are very many people across the country who are involved in these activities. So
is it not an entitlement?
It is. You are paid, but
yes,
as I said, it's a process. So the payment is as when you have received the request and verified that yes, this activity took place, and then you pay. But as I talk now, most of them have been paid their allowances.
Okay.
The challenge we had is that as the year closed also, we found that there was inadequate money, and we have included that in our funding that we expect this quarter to be able to pay the arrears for those who did not receive. But the majority of them have actually been paid.
When you say majority of them, what class? Because there are people that mop hospitals, there are those guys that sweep, those that slash, who give a hand to ensure that your work is that effective. Who has been paid and who has not been paid?
No. We as I said, once you are entitled, be a cleaner, a driver in an ambulance, and you are directly involved in the COVID management. Not all workers in the hospitals, for example, are paid. Okay. It's only that team that is directly within that CTU, that COVID treatment unit, that are entitled to be paid. Okay. And we do not discriminate. You pay us and when we receive the requests.
Yeah. Good enough I have only doctors here. Dr. Kabanda, I'll bring this to you. You're in charge of health promotion.
But I think before that,
okay,
there's something which Dr. Sarah has brought in, which members of the public should know, that despite the fact that we are in a pandemic, government is not being run like a private sector. If in my private business, if somebody is demanding me, it's just a matter of cashing immediately, as long as I have the money. With the government, even when you have the money, what happens now, like you have seen MPs moving across, what happens is that if you do not follow proper procedures of even verifying, because if they tell you that Alfred, Kabanda and Sarah have been doing this kind of work, if you don't verify, then you will be actually put to task to explain how did you pay these people without ensuring that these people actually delivered the work. And this kind of pandemic, even the number of people that we look at are not only those who are into clinical care kind of practice, not only those who are into hospitals. Those who actually community-based and they're supposed to be paid, you must be able to verify that work was done.
But Dr. Kabanda, how long does that take?
No, we have labored to explain. The challenge is that most people who actually conduct press conferences don't actually even consult Minister of Health prior. It would have been better for our colleagues to consult that we are going to engage media on delays, but how soon are you in terms of remitting this? So it would have been better for us from time to time to be able to explain. But what happens with human nature, even when you explain, some people are actually after making or engaging in media and actually appearing on TVs and what. But what we have labored through a number of engagements with health professional associations is that let them always endeavor to seek
attention.
To seek attention of Minister of Health for more information, so that they engage the public from an informed point of view.
Relatedly, Dr. Kabanda, the groups of members of parliament are moving around the country, but they come out with the same concern based on their own observations. So the health workers are saying the same thing and the MPs are saying the same thing. What exactly could be happening?
I will give you an example of the story you saw running on about Umbare Hospital. And in form of ambulances and ETC and expenditures of ambulances. And of course, I do not want to fault our senior colleagues, the MPs, but what happens is that before they engage media, it would have been better for them to seek clarification from Minister of Health.
For them, they are accountable to the public.
No. Because in a pandemic, we work as a team. So if you go to a regional referral hospital and particularly ask about a consignment, for example, or a service or a product that was sent in a region, because when you send something to a region, it sees as being a hospital-based kind of product or item. So they would have engaged the Minister of Health. And of course, what we are saying that maybe what we also need to do as technical officers is to orient most of our colleagues, including politicians, that how do we conduct a business in a pandemic? Because what happens, one word from a well-known MP can actually distort everything. And we don't want that to happen. So before they engage
you think they distorted?
Before they engage members of the public, in general terms, what we would like to see happening as technical people is that they need to consult members of the technical team at the ministry to get more information, so that by the time they engage members of the media, actually they are engaging from an informed point of view. So what happens if a particular section of the, say, MPs or other politicians, if they provide wrong information to the public will definitely believe them. And by the time we come out to correct, it will be too late.
Why would MPs really hate the ministry so much? that they say wrong information. The group in Kabale is saying there are problems this side, the group in the northern is saying the same, and the group in Mbale is echoing information that almost corresponds.
I think it's not about...
When you talk to the natives, they'll tell you, this side in the eastern, we have never seen a cylinder of oxygen.
I think it's not about it. But
Yes. What goes wrong, Dr. Kaman?
I'll give you an example. Why would somebody in a village, may I come from Chotera for example, if somebody has not had a problem and is going to be hospitalized, how would that person be able to see an oxygen cylinder? How? And in any case, even when you are troubled, if you are very sick, would you even mind to see how many cylinders are in place in a healthcare facility? It's not possible. When you are in need, actually, you may not even be able to see how many healthcare workers are attending to me. How many oxygen cylinders do we have in a facility? It's not possible. And remember, most of the critically ill COVID patients, actually, they are being wholesomely being taken care of by healthcare professionals without actually even relatives. So, but what members of parliament and politicians, to me as a technical person, I don't want to call it hate. They don't hate the sector, but it's a procedural issue that we may need to work on so that we all speak the same language. It is true, we may be having some pockets of ineffectiveness among members of the team, not only at the Ministry of Health, for example, but across. But we may need, as a team, to be able to have like jointed efforts in terms of communication, in terms of engaging members of the public, in terms of knowing what is the procedure. And if all of us, technical teams, politicians, and other stakeholders, we are working as a team in mitigating some of these challenges, then chances are high that at the end of the day, we shall be working as one.
Okay, Dr. Sarah remembered something. Did you purchase any oxygen, or did you ensure availability of oxygen in the plans as you were distributing resources as the ministry?
Oh, for sure, yes, we have. And in the first wave, we did procure oxygen plants to enhance the capacity of Mulago and also in Tebe, and because those are main COVID treatment centers, so we did do that. And in our the current wave of funding for this financial year, we are also in the process of procuring additional oxygen plants to enhance the capacity we have at all the regional referral hospitals.
Okay.
Yeah.
But have you heard about the scarcity alarms, and to a level that actually some people have died just because of that?
The scarcity has been there.
In some areas, people, even health workers, say we can't do anything.
No, but
we had a cylinder and it could only serve one person.
We have tried our level best to make sure that oxygen is there. It may not have been adequate, but it has been there. And we also were able to have some of the private sector supporting us with additional oxygen. Okay. So we have really worked on ensuring that oxygen is available. Okay. And we continue to enhance in anticipation that we may get another wave. So we are building on that, because we have seen from elsewhere that in other countries like India, where many patients were lost due to lack of oxygen. So we are really strengthening and working on that.
Let me hear from Dr. Driwale. I'll come back to you to share your plan about the third wave that every other area is talking about. Now that you're handicapped, you don't know where to get vaccines, even when the money was availed. What is the way forward? So are you just going to look at us die?
Now, no, we're not going to look at you dying. Government has put in place budget and the money to buy the vaccines, and there is consensus across government, both cabinet and parliament, that vaccines are now the in thing which must be acquired as a matter of urgency. So what I was saying is that money is not the limiting factor. Let that be very straight. So it means as a country, we have done what is required to ensure vaccines are here in the country. But what I also want to allay fears of the people is the constraint. You know, there are over 7 billion people on Earth. They all want to be vaccinated at the same time, and therefore, these are new vaccines being manufactured by few factories with limited capacities. So the demand is far beyond what can be met by those factories. So if the supply is less than demand, you expect stampede. So what we're suffering from is a global stampede. So the powerful countries which make these vaccines are the ones having first access. Just know that there are countries which invested in the research, in production of these vaccines, as a condition that they will be the ones to get the first access to the vaccines. We who did not invest before cannot compete on the same footing. Having said that, in this week, the decisions within government for accessing vaccines has now been increased. Many channels have now been opened. We are in touch with factories now to ensure that we try all available means to deal directly with the factories, in addition to dealing through COVAX facility and the African Union mechanism. And it is too early to say what these are. So, but going directly to the factories and acquiring the vaccines is now the new thing. So the public should be hopeful that vaccines are going to be here. Even through donations, we have got a good alignment of supplies which are going to be coming into the country. But now all our efforts as government to acquire vaccines are now in full gear.
What is the fact about claims we hear that some countries are questioning AstraZeneca? Actually, they say they are blocking some people that have been vaccinated with it from accessing their land and things like that. What is the truth about that?
No, the issue, you see, when Uganda is making laws, it makes it for Uganda. That is the primary objective. So EU was issuing those guidelines for their jurisdiction, and with respect to products which they themselves have certified. That is the primary objective. And number two,
so they barred people from accessing their area.
Now it is not about barring, and that's where social media added salt. The issue is that if you are coming from a country after having been vaccinated using a vaccine which is not authorized for use here, you will have to go through quarantine.
Okay.
It was not about outright stopping.
But why would they not authorize some vaccines?
This is
if
survival.
Those vaccines are really
survival.
That would.
You know, other countries don't take their countries lightly the way we take ours.
Yeah.
Survival of their citizens is number one priority. You remember Trump used to say America first? So they are not going to be making laws for others. They make it for themselves. So if you are coming and we have not allowed that vaccine inside you in our country, we will put you.
Yes, doctor, that's what I'm asking.
Now,
why would they question that particular vaccine?
Because
why would they refuse to approve it as a vaccine recognized in their area?
No. Do you know that vaccines which are allowed to be used in Uganda, we registered them by factory? The initial vaccines were from India, right?
Yes.
We registered Covishield, which is from India, to be used on Ugandans. When we got the doses from Europe, we said, no, wait a minute. We are also going to go through the process of registering the vaccines from Europe before they are used on Ugandans. So this is a mechanism for protecting your own. We want to understand. It is coming from Europe? Yes. Which factory? We want to understand the manufacturing processes, the safety. Is it the same? Before we put it on our register that it is allowed. So it is the same thing. But now, the good news is that discussions are undergoing between EU and respective countries to relax those conditions. Number one, 7 countries in the EU, because EU allowed member states to relax those conditions on bilateral basis. So over 7 countries have allowed use of vaccines from India for you to go in. Then number 2,
it has now shifted to 15 countries.
So now it has shifted to 15. And also yesterday, the communication we have got from the European Union is the effort to ensure that vaccination certificates from other countries are recognized. So we have been officially asked by the EU to go to check our systems so that the certificate issued from Uganda, forget about this paper which is for reminding you, the real certificate is going to come. So the certificate which is going to be electronically generated, which can be read by a phone, is coming. So we are studying their system as they have requested, so that we also submit ours to them, so that if you move with a certificate of vaccination from Uganda, they can verify that truly this
digitally.
Digitally. They can confirm that this is somebody Uganda stands by. So those people who are outside there forging these certificates, you would land yourself into a problem. You may be arrested in another territory, and your country will not be standing with you. So I think we need to learn, especially companies which are exporting labor.
Thank you so much, Doctor. Dr. Sarah, we had the COVID-19 with one variant by the time it came here. Right about now, we're talking about over 10. So what kind of plans do you have with all the lessons and whatever we have gone through? People languishing with lockdown. Yes, government is sending some money, but still it can't be enough for someone who is used to taking care of themselves. They know how to play with their coins and see how they survive. What kind of plan do you have as the Ministry of Health in terms of what you have learned, whatever we have gone through this time round, because we expect a third wave, there are no vaccines. So what kind of plan is in the pipeline as we move towards the end?
Sure, this brings in what we call everyone should be responsible for their
We have
health.
tried.
And we should continue.
Yes.
We should not give up, because COVID is here to stay. It's not going to go away today, tomorrow. So as Ministry of Health, or as a country, we have to continue employing all the preventive measures, because prevention, as we say always, is better than cure.
You have literally asked two key questions.
Yes.
One that targets the community and one that targets healthcare professionals. We have had a number of engagements with the professional bodies, and one of the key areas of concern is to ensure that we do what we call what we term as targeted communication with healthcare professionals, and continue having a number of webinars and seminars and meetings online in the current state. But we have also advised our colleagues at this level to ensure that they engage healthcare professionals from different healthcare facilities. Because one of the key issues that we need to strengthen is about infection prevention and control among healthcare professionals. But of course also our teams is still looking at some analysis, because we know that we do have life outside facilities where we work from. So we want to see out of all these people who have been found to be positive, is it likely that they got the infection from healthcare facilities or outside?
But how much are you doing to save them?
And of course, when you talk about infection prevention and control, literally it talks about us enlightening them on the essence of protecting themselves and understanding that they are at risk. And it also touches the perspective of what Dr. Sala mentioned, ensuring that we have the PPEs in place, so that every time they get in
As
contact,
you tell them to save themselves, to protect themselves, the protection is also available.
exactly. That's one of the key issues. But of course, you also need to know that many people look at healthcare facilities and think that if health workers become positive literally, you think that they have got the virus from facilities. And for us, we think that people may actually be a little bit more strict in healthcare settings, but relax a bit when they get out of the facilities. So, but of course, we also know that because we are seeing many patients who are symptomatic, we want them to address or attend to patients well knowing that Alfred or Kabanda or Salah may actually be positive for COVID-19. So every patient that comes to healthcare facilities needs to be treated as if he's a COVID-19 positive patient. So if we have that at the back of our mind, then chances are high that we shall definitely do better. The other component you talked about of the community initially is that currently, if you were following, last year it was more of us, more of the healthcare professionals, engaging members of the public, and at the forefront of the pandemic. What we want now, as Dr. Salah said initially, is that we want members of the community to be at the forefront so that the technical teams are able to just provide a supportive kind of arm. And since the pandemic has been here for quite some time, and we don't know that it's ending either in August or September, then members of the public should know that they have a 90% responsibility in mitigating the challenges of the pandemic. And as the technical officers, we have the 10% providing technical guidance on what needs to be done and how and the kind of support we can give when they come to facilities.
Thank you so much, Dr. Kabanda, for the information. Dr. Driwali, you told us you're waiting for the vaccines. The moment we get them, each one of us will get what to do. You shared your plan, and to you watching, the best we can give you is information. We wanted to know there's a lot of excitement about issues to do with accountability, and that's why we had these officials here to guide and clear the air, and I'm sure you are informed now. On my right here is Dr. Sarah Biachika, the Commissioner for Planning in the Ministry of Health. In the middle is Dr. Richard Kabanda, the Commissioner for Health Promotion, and the gentleman on the extreme right is Dr. Alfred Driwali, the Commissioner for Immunization and Vaccination in the country. My name is Micheal Lukomwa with the whole crew here. Wish you the best of the night. Bye-bye.